Hi, good afternoon, everyone. Thank you so much for joining us today. My name is Sharon Puddle, and I'm from Waitemata District Health Board. So with me, I have Delwyn Armstrong, who's our Head of Analytics, and I also have Penny Andrew, who's our Director of the Institute, and Jeanette Bell as well, who is the Program Lead for our Patient Deterioration Program. So if you do have any questions about the program itself, they will be here to field those. Otherwise, we're happy to discuss our different CLIC applications today. So if there are people in your organization who aren't able to attend today, we are currently recording the session, and we'll try to make the recording available after this, but we'll let you know when it is available. And yeah, so I will run through a quick overview of our CLIC implementation for you, and then Delwyn will go through a couple of examples of how we are doing complex data modeling to answer complex questions in our health environment. So if you do have any questions, please feel free to use the chat feature, and we will try to answer them when we've finished our presentation, but we may not get through all of them, just depending on timing. And again, Luciana will be going through those questions for us, and we'll field those at the end. So just to quickly give you an idea of our environment at Waitemata Health Board, so we did have an initiative that was started about 5 years ago called the Leapfrog program, where we had a number of focus projects for our organization which would have a significant impact for our DHB. And these had some seed funding from our CEO, and they would have incremental steps to build on existing infrastructure and projects. So just to give you an idea of the timelines and what we have implemented, so we had a mobility strategy to get Wi-Fi across our main hospital sites to enable access for our patients and our staff. And then this enabled us to have a mobile device management platform. And with those set up, we were able to implement e-prescribing and administration across our organization. We also have e-vitals, where we're doing observations on our wards on mini iPads. And we have e-orders for laboratory and radiology across our sites. So one of the things that we face when with having these systems implemented is that there was an impact on clinical workflow for our clinicians. So having to jump between multiple systems kind of affected their how they work with their patients. So we have custom developed some solutions as well, such as My Patient List, which is an app where clinicians can access their current patients. And we have an inpatient snapshot where we can get an overview from these different solutions that we've implemented in one view. So these are accessible by our clinical portal by our clinicians. So this, just to give you an overview, because we have so many systems now in place, we wanted to be able to leverage off the data, and we wanted to see this information at a more global level, which is why we wanted to implement a BI tool. So we selected ClickSense as our tool, and hopefully we'll be able to show you today how we've been able to address the lack of interoperability by pulling data from multiple data sources. So our program itself has been running for 2.5 years. So we started in early 2017, and we had 3 sort of drivers for our implementation, 3 priorities, and the main one being to have a clinical focus. We already had a lot of existing operational, finance, and military required reports that were available and presented in other systems. So we wanted the solution to have a clinical focus so that we can make data available to our clinicians and people looking at, making decisions around patient care and outcomes. So with our apps, we're currently at about 45 published apps. We have identified clinical leads for each of our apps, and they're involved right from the start in terms of the concept and design and testing. And then once they're published, they also are involved and they become our champions and actually take people through the apps as well. So this is really important because the apps are designed for the clinical context, and it helps our clinicians to understand the data, and it's more meaningful for them. And we found some limitations with other implementations is the lack of licenses. So we do have an enterprise-wide license. It means that users from all levels, so staff from all levels in the organization have access to the apps that are published. And this is quite important because it means that everyone's looking at the same data. And this supports our organizational aim of transparency and democratization of data. We've also undertaken a lot of training in our organization to increase the skills in our DHB for click development, so that there are areas outside of our implementation team who are developing ClickSense. So we're seeing other areas like finance and facilities currently developing as well. That's just a quick snapshot of our ClickSense implementation. Started talking a bit about our data environment. So this just gives you a brief overview of what it looks like. And so we have about over 30 main clinical systems that we collect data, and a lot of it's not hierarchical. We have a mix of an old data warehouse and a new Westgate Red warehouse that's being built, and then an operational data store, which is a replication of a number of our source systems. But as you can see, we are building a lot of Click apps that go across these systems. So when I talk about interoperability, this is what we're doing. So we are able to pull data from multiple systems so that we have a better overview of what's going on across the whole patient pathway, rather than looking at a single data source and having a silo app. Want to add to that, Dylan?
No, that's good.
No? Okay. Yeah. So I'll pass on to Dylan.
Hi.
Our data model.
Hi, I'm aware that I could be teaching you to suck eggs because you're all Click aficionados, but we've found that really complex data modelling allows us to answer questions at a low grain across the data model. So I've got two that I'd like to show you. First of all, I don't need to teach you or explain to you why Click, the associative model, is an advantage over SQL. But this slide I've put together to show that, you know, you can have many orders that can have exams in radiology, or you can have exams that have orders, and there will be some orders that don't have exams, and there'll be some exams that don't have orders. And unlike SQL, you don't need to choose which of the grains you're going to present. You also, you know, might be interested in whether the order happened during an inpatient event, or if you're interested in choosing wisely initiatives, you might be interested in which inpatient events didn't have an radiology order. Anyway, that just is a quick overview. You might want to use that slide for other people to show the problems that we experienced with SQL, or the limitations, and why the associative model of Click gives us quite an advantage. So this is how we've modelled radiology. Now that's a lot of detail, so I've just put some little flags on here to show you what you've seen in this model. We've got e-orders, we've got radiology orders, which are coming from our RIS system, we've got e-referrals coming from GPs, we've got the exams themselves, we've also got a separate set of data about contrast procedures to give more information, inpatient events, of course, radiology wait lists, because patients in the community are put onto a wait list, but also we're interested in wait lists for operations to know whether that radiology procedure, or the wait for the procedure, is holding up a surgical procedure. We now have a system called SmartPage, which is how we call it Uber for orderlies. And so we're interested to know how long it took orderlies to move patients around the hospital, and if that was causing a delay in radiology. So, of course, we're interested in patient demographics as well. So all of these pieces of information have come together to give us a picture of radiology. We use a master link table. I don't know if you all use this. It's very weird not getting any feedback, but I'll just imagine that you're nodding quietly. So with this sort of modelling, this associative modelling, it's multi-directional. It's not the orders and whether or not they've got exams, it's all of the orders, all of the exams. And this is really important. Every data point in every field is associated with every other data point anywhere in the schema at the atomic level. And we've made it a rule that we will always show the data down to the patient level. Otherwise, we're not taking advantage of this new modelling ability. This gives you an idea of how the master link table works and how it makes the associations between the different data sets. So as you can see, I'm not going to take you through the whole table, but you'll have this on the recording. You can see that some orders are associated with an inpatient event, but some aren't. And some are associated with an e-order and some aren't. Right? Anyway, we're moving on to, I want to actually demonstrate the deteriorating patient dashboard because all of you will have rolled out this program across your hospital, the patient deterioration program. That's right. We've got the experts here, Penny and Jeanette, who can answer specific questions, but this is our data model. Now, these are the pieces of information that we've brought together. What Sharon showed you were all of the systems that we've put in and the fact that they're unconnected systems at source. This is the way we connect them together. So they're all connecting together around what we call a patient journey, which is all of the inpatient events that are contiguous joined together, okay? So what we can see here is we're interested in ED presentations, our vital signs, and our early warning scores from our eVital system called Patient Track. Oh, right, I can point to this, can't I? In Patient Track, we do sepsis screening. We record resus calls, or the outcome of resus calls. We record calls between nurses and doctors through our smart page system. That's not entirely rolled out, but it is for house officers. We record lab results and requests, deaths, not only inpatient deaths, but in the community, medications through our MedChart system, and of course diagnoses through ICD coding, inpatient stays. Right, we also now have a system that records referrals to ICU. So we not only know whether people were referred and why, and whether they actually were accepted, but also whether they did actually get in. And like the other data, sometimes people are admitted to ICU without a referral, and some referrals don't have ICU stays. Oh, electronic referrals, yes. And of course, we're always interested in patient demographics. All of these hold together around this master link table around the journey. So now I'm going to demonstrate what that gives you. Oh, well, first of all, that means we can ask questions across the model, like how many patients in the blue zone? If you know about the deteriorating patient, you'll know what I mean by that, the serious zone of the early warning score. And how many of those trigger an escalation? Here's another question for those with a diagnosis of sepsis. What were those triggers? You know, what was their sepsis screen? What were their early warning scores? And what were the lab results? Or how many patients were admitted to ICU with suspicion of sepsis, and what was their outcome, right? So, of course, you could carry on thinking of lots of questions across here, this model, as clinicians are now. But it's early days yet. This is our dashboard, and there are so many places I can go with this. I'm going to start by looking at sepsis coding. This, as you saw, that we've got about 12 different screens or pages that give us different aspects of that model. This is showing the number of sepsis cases as coded by the McPherson 3, which is a set of ICD codes that are known to one way of identifying sepsis in our ICD coding. Another is looking at suspicion of sepsis codes, which are a broader range. And what you can see is that, of course, the McPherson 3 is more specific, and the sepsis suspicion of sepsis codes is a larger group and so more sensitive. But what that means is the McPherson 3 is better at detecting the higher risk cases, and therefore they have a higher mortality rate. So what we can do with this is select all of those who have been coded as having sepsis and then look backward as if we're doing a case control study. I'm going to choose those who had a McPherson 3 score in 2019 and then move backward and have a look at our earlier in their pathway, what early warning scores were triggered. And as you can see, 3 of them were triggered in the blue zone, and yeah, I won't read out all the numbers, but we can also look at what hour of the day that happened. I'm going to change this to that showing proportional split, but if we look at the number of cases, we can see that there's a lot of activity happening around those standard times that nurses are doing the obs, right? But you can see that outside of those times is when the blues are more likely to be happening, right? So we might then have a look at the how we responded. So we've got a page here looking at first of all the sepsis screen. We can look at where it was positive. I can just choose yes. Have a look here and see what the nurse chose as being the most likely reason for that sepsis screen being positive. And what we can see is most likely here is infection. Down here you can see all of the antibiotics. So again, you know, think that looking across that model at the med chart data, we might also want to zoom in on those that had a blood culture when they move down further. Now, what you can see here are patient details. This is the NHI that's disguised for today, but right next to it is the link to our clinical portal. Normally you'll see an NHI, and then you can link straight through to the clinical portal to get a higher level of detail. Right now we're going to move to the another page, which is the laboratory results. Now this is very detailed, and so this is probably the slowest, right? Okay, I can choose a patient, and then we can have a look and see what actually happened for that patient. You can see the abnormal results followed by the normal results. You can see when sepsis screen happened, what the reason for the screening positive was. And if you did want to have a look at all other tests, you could easily take that filter off and have a look at the rest, right? Okay, so the outcome, death. Do we want to look at that? Right. I'm getting heckled. Did they die? Right. So yes, sure. So we could, right, well, yes, very good question. We have a sepsis dashboard here. I've narrowed it down too far, so I'll just take off a few of our filters here and have a look at all of our sepsis pathways in the months that I've selected. What you can see is, now we looked from the point of view of the patients who had coded as positive, but we could work from the other end and say, how many screened positive, and how many of those ended up being coded, and then how many of those ended up dying in the inpatient setting. So you can look at this pathway either way. The Sankey is just wonderful, isn't it? So that's a fair bit on sepsis, but one other thing that I thought you might want to see, recently we added resus status to our admission note. So now resus status is collected electronically for all of our inpatients. What you can see here is the current inpatient status of 43. But of course, click allows us to drill into this. That doesn't seem good enough, really. We've only recently introduced this, so I'm going to look at the more recent months. And then I'm going to have a look at our 2 hospitals where we have introduced the resus status recording. Still not good enough, 52%, but the person who introduced it said, well, it's really not fair to expect them to have done that necessarily in the first day, so I'm going to select everything apart from those with a very short length of stay. And we can see that that percentage is really good at 82%. And actually, if we filtered down by age, we'd see that it's even better. And you can see that, I want to change to service. You can see that some services are better than others, and that tells us where we need to do some more work. Okay, so again, every one of these screens gives us a drill through to a portal, and if we went through to admissions, we'd be able to see which admissions do not have their resus status recorded, and therefore we can do something about it. A lot of this work we've yet to set up because this is very new. And what I'm showing here are the of those who were not admitted, what were the reasons for not being admitted. And this is information that we never had before getting this recorded, right, as Penny said. Yeah. We also have a simple explorer here that can show us where we can have a look at patients who reached the blue zone on the early warning score, and then have a look at what happened. We can see how many had an ICU referral, but how many had an actual ICU stay. Quite a bit fewer. And then we could have a look for audit at those that had an ICU referral and then didn't get the stay and what their outcomes are. So there's also so much data here that we can use to refine our identification of sepsis, and that's what we're intending to do. Here you can see how many had a call out to our critical care team, outreach team, and how many actually had a resus call. So we can drill into any of those. Here are the patient details below. Here are the pathways. I seem to have chosen something very specific here. And yeah, so I mean, as you can see, there are so many other places we could go with this. How many had a death? And you can see that the early warning score is differentiating really well, actually, but we might be able to do even better. We also have quite a bit of information on our resuscitation team call-outs, so we can know how many were cardiac arrests. How many were for CPR? And Jeanette, I might need to call you in on this if I get this wrong, and how many cardiac arrest calls we had.
I think this has been a challenge for all DHBs, and it's part of the patient triaging program. But this is actually identifying patients who you want to know which ones are true arrests and which ones are deteriorating when you get that resus call. And we've never been able to do that. So again, trying to find a way of electronically recording that and then getting this data so you can get comprehensive data about which patients were ones where had deteriorated, and they called a made a resus call, and which ones were actually just true arrest, like those ones that you weren't expecting to arrest. So for us, it's again part of the CLIC program has been amazing, because it actually precipitates you to ask, well, to do this really well, you need a comprehensive data source that takes you right back to how do we collect this data, and ultimately we keep constantly asking, how do we do this electronically in terms of the data collection, and hence you have clinicians leading these CLIC app developments, because that comes back to how do we do data collection that integrates into the clinician's workflow, so we're not asking them to do anything extra or a tiny bit extra that they have to do. So creating a form that can a lot of it self-populate and continue to develop that.
With the observation sets, we've already had a look at this page, but it's interesting to see when in the day the blue zone are triggered. So this shows you the shape over the day. You could also use this for individual patients. Choose a patient and then look at all of their triggers by looking at the particular date. Okay, well, I think that's probably exhausted everything that you could be interested in there. We might as well, yeah. Oh,
I'm happy people just if they see this, talk a bit about what we're doing with sepsis, because as I said, this dashboard and the Daring Patient dashboard is really very new, and so it's really in its exploratory phase. But sepsis is around, so international evidence is around about 30 to 40% of your Daring Patient programs patients, and probably more. So a really big cohort of patients that you're looking at. So hence we've really got started to drill down on sepsis. But the challenge in data and how to identify sepsis is really challenging. We've got a real advantage at Waitemata DHB, again, because of electronic systems. So we've got a real-time reporting in terms of our eVital system, which has got the sepsis screen built in it. So it's an automatic scoring that can create an alert for our clinical staff to say suspect sepsis, and then start this clinical algorithm. So that's your real-time data that we can use on a dashboard to tell us where our patients who have screened with suspicion, and we can track their progress, and then use your coded data for your longitudinal monitoring of rates, and then drill down on where those sepsis cases are occurring and the outcomes. But I think just very briefly, this is such a good example, the sepsis one, of what CLIC does. Again, what it does is it makes you go right back to the beginning and say, how do you define the measures and the metrics, and actually start working at your coding and cleaning up your coding data. So it really does actually precipitate a whole lot of work in terms of looking at your data, structuring it, but also right back to the level of documentation with clinicians and getting clinicians to document things correctly so that it can be coded correctly. So it does precipitate improvement, not just in terms of clinical improvement and improvement programs. It's actually a really good way of precipitating improvement in your data and data integrity and how you measure things.
We have chosen to create apps that were around particular areas. We could have created one app for the ICU referrals, for instance, one for the eVital data. In fact, we started going down that path, didn't we? But we kept finding that the questions we wanted to ask were never just about early warning scores. They were about early warning scores and how they related to laboratory results or mortality or ethnicity. We always make sure that we have ethnicity in every single app as our in an attempt to make sure that we are providing equitable care as much as possible. So that's our commitment to equity. So we found that the really big apps, while they can be slower, they give us so much more richness and the questions that can be answered that I think it's worth the slight hit on speed.
Yeah, and I think also because we build especially those foundation like patient journey apps, we've got an inpatient explorer and outpatient explorer. They go and convince me, and I have to say depending on the but they have been really invaluable because you don't have to, it just reduces the amount of building you have to do. And they make it easier to, sort of iteratively, when you're building further dashboards, once you've got that foundation and you've linked that data, then building the next one becomes easier. Well, I don't build them, so but I'm told, but they happen faster. So I think that actually having some planning and just start designing how you're going to develop that is really, really critical to the speed of the and the uptake of this. And that's really critical for commissioners because, as many of you will know, commissions need this fast. And the frustrating for them is the building, and they get terribly excited about this fast, and you need to be able to work, relative speed.
We can't overstate the importance of having the clinical focus, and actually ignoring our operational metrics for the first year or 2 years actually. What's happened is all of our apps have started to incorporate operational metrics such as length of stay or time to theatre, but it started with what the clinicians wanted, so they have so much engagement in the whole Click program really. In fact, we've got 4 clinicians who do the data modelling themselves, so all you have to do is point them to a data set and they'll pull it into their app, and okay, Sharon helps to this is the extent, but some of them they are senior medical officers, and they actually take on the data modelling themselves as well as the presentation layer.
Yeah.
Okay, well that's probably enough from us. Shall we take the questions now?
So I've got a few questions, pretty simple to get through. So how do we prioritize apps? So we didn't really cover that initially, but when we kicked off our program, we had a steering group. We already had quite a lineup of apps before we even kicked off our ClickSense implementation to start developing. But I guess as a priority, we also wanted to work with data that we were familiar with. So with our core team of 5 people in our Click implementation team, we chose data sets that we thought we knew, and then we would learn the tool in that way. So our first lot of apps were Explorers. So we created an inpatient and theatre Explorer, an ED Explorer, an outpatient Explorer, and then we migrated across quite a number of audit apps from ClickView. And then outside of that, we had some clinical champions part of our steering group. So we worked with them to identify the dashboards or specific specialty apps that they were interested in.
We could share we started off with a spreadsheet where we recorded the readiness of the apps that were requested. So that came down to whether there was strong clinical leadership and engagement from not just one person in the service, but the department, or at least a few of them. Whether or not we actually had the data shaped up in our red warehouse made a bit of a difference, but actually because it clicked, we could take it from any environment. It just takes a bit longer. What else did we have in our? Anyway, we can share that if you like. There were a few other things. Did the services have a good underlying model of what they wanted to do with it? For instance, we started with general surgery, where they had developed clinical protocols, pathways, and they wanted to see those visualized. So we knew that they were more likely to actually use the information once they had it, and they did too. They started some clinical redesign programs off the back of the information that they saw. So not only diagnosing the problem, but tracking the results.
That's been a program working with our clinical director of general surgery for the last 3 years, but that's a really good demonstration of these Click dashboards being used for improvement and tracking improvement, and with real-time data, which is great. So there's a whole sort of quality improvement program that the clinical director and his department running, and they're looking at criteria-led discharge, getting patients into theatre faster, doing ultrasound, bedside, point of care, scanning for patients with cholecystitis, and doing day case, trying to do day case procedures and finding an area in a procedure room for day case abscess surgery. And yeah, a really good example of a dashboard being used for quality improvement in real time. And the other beauty of these, is for any clinicians in the audience, of these dashboards, is that they are an amazing audit and research source. So it's certainly starting to reduce the requests we get for data extracts for audit and research, because you can point them at the dashboard. They obviously do need support from the team, but they can do basically a huge amount of audit off these dashboards. So the registrars are picking this up.
Oh, how often do you refresh? Right, most of the data is overnight now, so from yesterday, but we do have some apps that are refreshed every 10 minutes. We've got a current patient app, one that looks that presents length of stay for bed management. So it actually presents a predictive algorithm predicting length of stay for surgical elective patients, and that's refreshed every 10 minutes. Could you show the doctor smart page calls? Okay, right. Well, let's see. Can we get back to that? And can you select part of the journey and identify where the patient's coming from and going to from that point? Have you got an app about flow from ED related to ED 6-hour target? Yes, we do. We've got an amazing app developed by Sharon and one of our emergency medicine pediatricians, and yeah, we could spend an hour on that alone. It's amazing. It's very comprehensive. So we'll have to think about how we can share that.
The department's using that for workforce modelling, looking at the nursing workforce and the levels of nurses and nurse practitioners, and the model of care for the nursing workforce, and likewise for the medical workforce and allied health workforce, as well as flow. So there's an improvement program in there at the moment using that dashboard and trying to cohort patients and get a more rapid movement through the department. So that's a really good example of a clinician leading the use of a dashboard in real time for flow through ED.
You asked about the doctor's smart page calls. As I said earlier, we only have these for house officers at the moment. So we're part of the rollout will extend to registrars, but that's going to take a few more months. But you can see the category here. Choose the category. I need to move the questions out of the way. You can see the, minimize that, of course, that makes sense. So you can see that you can see who the call came from, what the category was. I'll take that off so you can get a better idea of what categories we have here. Laxatives, blood tests. Right, okay, so what else have we got here? Who the sender was, when it was sent, the hospital, and then you can drill through into portal. Okay, so let's see the next question. I want to do that. Do any of these dashboards have any predictive modelling? Oh, I've just answered that. Yes, we've got one predictive model that looks at the length of stay, the expected length of stay for people who join the elective surgical wait list. So from the point they're on the wait list, based on their ASA grade, their comorbidities, age, plain procedure, we can predict length of stay to, we're up to 78% to this exact date, actually, that's in the last month. So it's a pretty good predictor. We're out by 1 day or spot on for 95% of patients. Am I overstating that? Or is it 92%, something like that? So it's quite a good predictor. we developed that with a crowd called iVise. What's the next one? What is the logic for linking data sets? Okay. Do you look at tests during a stay or those prior to or post? Yes, so in the model that I showed you, it was all held together by the patient journey. This is a term we use, which means, oh, can you hear me? That this is a term we use that is shows the whole hospital stay. So then we look at laboratory results that occurred within that time. Now we could show laboratory results outside of that time. We've just chosen to limit that in this model because there are a hell of a lot of laboratory results. So it would create quite a weight on the app. So we do have a separate laboratory explorer actually that we're developing that shows absolutely every laboratory result. Now, does that answer that? So the logic is, does this happen within the journey? Therefore, that is tagged to the journey. There are other links if we've got something more explicit. For instance, an early warning score, an observation set detail is linked to an observation set. So that's at a more specific link. But we can share that model with you. Just curious how Click was chosen over other platforms such as Power BI and Tableau. Did you see any pros in Click over others? Yes. Now, who wants to answer that?
Yeah. So we had quite an extensive RFP and it came down to 4 different products. But as Delwyn covered at the start about how we can go across different data sets and only have use the associative data model and Click to actually be able to see data where there's no direct link. I think that's quite unique to what Click does. So that so that's one of the things that we have been able to leverage. And the explicit joins tend to need to happen in the other tools. So can't say for sure because we're not experts in the other tools, but that's one of the benefits of what we've been able to do with Click is to leverage off the associative data model, create these master link tables. Some of the joins aren't absolutely explicit, so we match against similar date time fields as where we can. There's a lot of work in the data models, and we're happy to share them after this if you wanted to actually look at the code or the data models for other apps. Because there's a lot of logic behind it, but that is one of the big benefits. And
we can also say that Acumen presented very well in the RFP, and we were really pleased to, we knew that we'd be able to work well with Acumen because we needed a good partner to help us put it in. It's more than just the tool, it is the whole process of embedding it in your system, in your organisation. The diabetes dashboard actually was developed by a diabetologist. And actually, we know very little about it. We leave them to it. So but we can, I guess we can keep all these questions and get back to you, James, and let you know what's in there. Can you show the ED Explorer? Can we put that aside just in case there are more on what we've done? But yeah, we could do. Perhaps, Shania, we could work out how to do that separately. Actually, that's a good point. When we prepared the dashboards here, we obfuscated the NHI, so we can't just open up some of the other ones because they will have patient information in them. So we'd need to do a little bit of background work before we could show you actually.
And what we admission document we call our A to D planner. So we're actually we're now in the process of going paper light on our wards. So we've got an electronic admission to discharge planner. So that's the admission document, and we're just rolling out across the 2 hospitals now progress notes, which will make up the bulk of the electronic file for a patient. So in the admission note, electronic admission note, there's a specific section that we've designed for the resus status of the patient, and that comes when Delwyn showed you on the, or Sharon showed you on one of the first screens, was what we call our inpatient snapshot. So when a clinician comes and it's particularly used for ward rounds, you have all your key information in clinical portal on one page, all hyperlinked with very rapid access, and on the top left screen, really visible in the in that patient snapshot, is the resus status of the patient with quick hyperlinks to the full details of the resus status.
Ward whiteboard as well. We surface that resus status on our whiteboard, and also in on iPads now, in something that we call nursing snapshot. And so the nurse carries around the resus status for all of the patients in her pocket, or his pocket. What else have we got?
Does ClickSense have control charts for quality improvement?
Woo! Yes. Sorry, we lost connection to our presentation, but we do have control charts. So actually, Dan and Acumen helped us to set up the first prototype. So we do have them in place, and we can send you some examples. And Acumen themselves and Dan actually have developed an extension. So if you wanted to have a look at that, they have it available through the Vizlet library. But we had their very first prototype using most of our apps, actually, just to be able to look at metrics. So again, we can share some of the screenshots from our apps today, and also show how we're using it across other apps that we have. We also have a number of posters and things we have available. So happy to share our work.
And I'll get Delwyn's confirmation if people are interested in the future, is a head and neck cancer app related to acoustic neuroma, but it's a really good example of how a model and a prototype for us to actually track our cancer patients. So patients, this is for an ORL surgeon tracking patients with for ORL service, acoustic neuroma, and identifying those patients and making sure that they've had the screening according to the treatment protocol, and identifying, using the dashboard not only for outcomes, but also making sure we're screening them appropriately. Are we screening them too frequently? So that's the choosing wisely work. And are we missing people in terms of that they haven't received screening when they or surveillance when they need it? So I think it's another really good, exciting model in terms of the potential for these dashboards.
All right, so just a couple more questions before I think we're about to run out of time. But just around users and how we're supporting them. So with the number of apps that we have developed, we have identified that because they are quite complex, we are running a series of sessions that are specific to the different apps that we've developed. And we now have a user guide, so we're just running a test session tomorrow, actually. So there is a bit of work on our end to start rolling it out. But our users are, the number of people using our apps is growing quite rapidly. And just there was one more. Any regular reporting? Yes, actually, so we weren't able to show you, but we did. So one of the things for the NZUs and the patient deterioration programs, that we have to report some quality safety markers. So we actually have a dashboard around the audit that's carried out. And again, we can share that with you. Some of that's automated because we can pull the data from eVitals, but we can collect all of that and present it in the Click dashboard. So that's used by the charge nurses to look at their results, but we can also run the reports from there on the monthly basis, and also for our falls and pressure injury audits. And our size of our team, I said we started with a team of 5, and we had our vendor Acumen involved on the ground just to get our infrastructure up and running and to actually provide support, because we knew we needed to grow the skills in-house. But we've provided training, and we've customized our training and provided training to about 20 odd people within the organization at different levels. So we've got people who are just doing the data visualization side, and then others who are also doing the modeling. So as I said, we have about a third of our apps developed by people outside of the team within the institute. yeah, and it is growing, so there's a lot of interest. I think we've covered most of the questions. We'll keep a copy of the questions, and for those who haven't answered, we will get back to you. But really appreciate everyone's time today. Just one more thing from Acumen, they do have another webinar running on the 14th of August for the finance and procurement team. So if you're interested, there'll be again another invite coming up for that. Please register. Appreciate everyone's time, and we'll so the Acumen team will be in touch with the recording. Thank you.